So when I saw the title of the talk, I was like, perhaps they want me to put David back in a Petri dish or something. I decided I didn't want a Petri dish, so I did it a bit artistic like that. David has had a lot of work done in basic research, in clinical research. He has a lot of publications. And so when I was told to, prepare this presentation, I tried to find his papers. I included all papers that had DJ back or D back because he uses both. And I excluded, the other backs. So I kept the friendly backs in the study and I kept the others out. I found this paper and I thought I wanted to share it because I think the thinking behind the paper is really interesting. Here, David was looking at enterohepatic circulation of noethistyrone and looking at the impact of antibiotics on that. Normally, you'd think just about the pharmacokinetic interaction, and then you forget about, what the mechanism could be. But in this paper, David also went on to look at the bacterial flora in the gut, and he found out that the antibiotics that were being used were decontaminating the gut, and the ability of the microbes to deconjugate the steroids that had been put in the gut were gone, and so concentrations were lower in plasma. So this was in a rat model, and I thought it was a really interesting way of looking at it because you don't just approach an interaction from one point of view. That, of course, sparked on several other studies because I wanted to know whether this really translated to a human effect. Enterohepatic circulation as a mechanism for drug-drug interactions, would that really translate to, say, impaired effectiveness of contraceptives? So David and his team members conducted several clinical studies in patients. In two of the studies, the first two studies, they looked at rifampicin. The first one was rifampicin and noethistyrone, and the second one was rifampicin and ethinyl estradiol. In both of those studies, they found lower concentrations. This we know has to do with the inductive effect of rifampicin on transporters and cytochrome P450. But they did two other studies looking at ampicillin and cotrimoxazole, and they did not find, changes in levels of ethinyl estradiol, levonorgestrel. With cotrimoxazole, they actually found a slightly increased concentration of ethinyl estradiol. So I've put below there two reviews that have been conducted after all this work has been done. Basically, talking about the debate as to what exactly is the interaction between antibiotics and oral contraceptives. And in the first one, it's sort of nuanced and it's accepted that there will be few patients that would have low concentrations of the contraceptives, and these patients might be at risk of impaired effectiveness of their contraceptives if they are using drugs like ampicillin. But the second is quite adamant and says that's a myth. There is no evidence of decreased effectiveness of oral contraceptives with drugs like ampicillin and cotrimoxazole. So we know that there is a limited role for enterohepatic circulation as far as the effectiveness is concerned. But I thought it was a really interesting way to go about investigating it and to think as a researcher. I thought I'll share it. And now the other paper I wanted to bring up is really more into the rifamycins, rifampicin, rifabutin, rifapentin. This is a recent paper, 2013, that systematically looked at the inductive effect of these three drugs in human hepatocytes. If you look at this diagram and you focus here, I think the key finding really is concentration-dependent induction of cytochrome P453A4 by rifampicin. But one interesting issue in the discussion is that you don't really see a plateau. It continues to rise. And it's not really clear because the concentrations here that have been used are those that you would find, say, in human patients. But if you haven't really seen a plateau, does that mean increasing the dose of rifampicin could still lead to further increases in induction? And so this is another intriguing area that warrants further clinical study. But this really forms the basis of a lot of the interactions that you will see with bacterial infections and HIV drugs. Now, I think put it in context, when I saw the figures, I did a double take again. In 2014, 1.5 million people actually died from tuberculosis. 1.1 million of them HIV negative, and about 400,000 were HIV positive. But that does not really tell the full picture. About 43 million lives have been saved since 2000, and this is really because of expanded access to treatment, rifamycin-based anti-TB treatment. And if you look at key recommendations, normally in a talk like this, I would use the WHO recommendations, but I wanted to bring out the CDC recommendations because I think it reflects some of the challenges that we have in developing countries and some of the differences in Western countries in the way TB and HIV are managed. Now, the key recommendation is TB HIV should be treated with rifamycins for the full course of TB treatment. Now, for the full course of TB treatment, is something that it would surprise you is actually relatively new to many high TB, high burden TB countries. So Uganda and Nigeria, for instance, would only have transitioned to a rifamycin-based TB treatment for the entire course in the last 2 to 3 years for all their patients. And one of the concerns really has been how do we manage drug-drug interactions with antiretroviral drugs? WHO has recommended rifamycin-based treatment since 1990, but when drugs for HIV treatment were difficult to come by, say in 2004, 2005, countries had to make do with what they had, which was nevirapine. And one of the ways to manage that was to wait until patients completed the intensive phase of TB treatment, which is the first 2 months, and they've completed rifampicin, and then initiate nevirapine at that stage. In other cases, you actually, if the patient had maybe a really high CD4 count, you could even wait until much later before initiating nevirapine. So the second recommendation here is that efavirenz plus 2 NRTIs is preferred when using rifampicin. I think this is accepted worldwide now. But of course, if you didn't have efavirenz, say 5-10 years ago, you would have had to make some difficult decisions. The next is when efavirenz cannot be used, nevirapine without a lead-in may be considered where options are limited, and I'm going to talk more about that shortly. The next is about rifabutin, used at 150 milligrams daily with boosted protease inhibitors. Now, this recommendation works if you have rifabutin. Now, rifabutin is more expensive than rifampicin. Rifampicin generally comes free of charge to patients and even to programs in developing countries through WHO mechanisms. But if you don't have rifampicin, if you don't have rifabutin, you might actually be stuck with boosted PIs and rifampicin. And the one drug that is even mentioned or discussed in guidelines is lopinavir-ritonavir. And in that case, the dose is doubled, but you really have to watch for toxicity as well as other concerns like treatment failure. So that would be the kind of consideration that would happen in developing countries with limited resources. For integrase inhibitors, as of the time the guidelines were released, raltegravir was what was mentioned, and here it says you just double the dose. Subsequently, dolutegravir became approved, and it's a similar approach. You increase the dose of dolutegravir from 50 milligrams to 100 milligrams. There's going to be an interesting talk tomorrow where we're going to look at the interaction between cabotegravir and rifampicin, and so we'll look at that. But I wanted to bring up this recommendation about when efavirenz cannot be used, use nevirapine without a lead-in. David and collaborators Sepi Mary Seiku came up with an idea of actually investigating this as many as 10 years ago. It was actually in 2006 that the protocol for that study was finalized. And if you look at this slide, you see box plots. And there are two groups. The group in blue is the group of patients that initiated nevirapine with the standard dose escalation, and the pink box plot are those that started with a full dose of nevirapine. The red interrupted line really refers to the MEC, which is about 3,000 nanograms per mil for nevirapine. And we found that at 7 days into treatment with a lead-in, concentrations were quite below 3,000 nanograms per mil for actually most patients with the dose escalation arm. And even with the full dose, there were still quite a number of patients that had subtherapeutic concentrations after 7 days of treatment. However, this study, I think, was quite useful because it helped to explain how, one of the trials that was subsequently conducted, which was a large RCT called the Carinemo trial in Mozambique, where nevirapine was initiated without a lead-in. I think total number of patients in that trial was about 600. And they were able to show that efavirenz, had a virologic suppression of about 68.4%, and nevirapine without a lead-in had a suppression of about 60%. So while nevirapine is not non-inferior to efavirenz, this would be a valid option to consider when you don't have options. So the second has to do with, I think this more, let me go back again slightly. Right, so this other recommendation says you start your rifamycins and you use it for at least 5 to 7 days per week in the intensive phase in developed countries. In the developing countries, we have fixed dose combinations that are used daily, but developed countries tend to be able to have more flexibility in their TB management. So it says 5 to 7 days per week in the intensive phase, but in the continuation phase, some clinicians will actually reduce that to about 3 times a week. So this study was an interesting study by Helen Reynolds, who works also with David Back's group. And here they were trying to look at the effect of the drug interaction with rifampicin when raltegravir is given daily, but rifampicin is administered thrice weekly. So previous drug interaction studies would have used daily rifampicin. And with this study, they were able to demonstrate that they were able to get, by doubling the dose of raltegravir to 800 milligrams twice daily, they were going to be able to achieve higher concentrations of raltegravir, 76% and 84% respectively for Cmax and AUC, and well-tolerated clinical outcomes. And this is actually recommended in that paper as an approach to deal with that. So once again, a different way of thinking about it and thinking about what exactly the patient is really getting and trying to figure out what the effect of the interaction is. Now, I was asked to talk about bacterial co-infections, so I took the liberty of bringing up some issues of malaria and TB co-infection. Because I don't think many people are aware that David Back actually did some work on antimalarials. So in 1990 and 1992, there are 2 papers that were released looking at the drug interaction between ampicillin and mefloquine and tetracycline and mefloquine. In both of the studies, the AUCs were not significantly increased. There was some talk about enterohepatic cycling there, but I don't think that really caught on. But subsequently, there was another study, and this study was looking at artemether lumefantrine and rifampicin. So this is another study that David was involved in terms of developing the concepts. And the issue here was that the WHO had asked countries to migrate away from the regular antimalarials that were used and to switch to artemisinin combination therapies. And these would generally contain an artemisinin, either artemether, artesunate, or dihydroartemisinin, and it will be paired on with a drug, a partner drug that has a much longer half-life. So while the artemisinin is responsible for killing most of the parasites, and it's really quite efficient at doing that, the partner drug makes an inhospitable environment in blood and stays in plasma for a prolonged period of time to ensure that the last remaining parasites are killed off. So Uganda, most other developing countries switched to ACTs, I think in 2004. But really, there had never been any interaction studies between the antimalarials that the WHO had recommended and the TB drugs that were already being used. And so a situation is you get the TB program of a country providing rifamycin for the full duration of treatment. Patient has a fever, goes to a clinician, and the clinician brings out the free antimalarial drug, which is an ACT, and presents it to the patient. So we conducted a study in Uganda, and here we found that artemether exposure was reduced by 89% by rifampicin, and dihydroartemisinin is the active metabolite of artemether, and that was also reduced 85%. So really, the killing potential of your regimen was gone. And even lumefantrine concentrations were reduced. There's an error there. That's not 89%. You should have read 68% for lumefantrine. So the conclusion really from that study was that artemether lumefantrine should not be co-administered during rifampicin-based TB treatment. When the study was completed, the manufacturer contacted us for information and submitted that for a label change to the FDA. When we presented the information to the Ministry of Health in Uganda, the question was, so what do you want us to use? And it turned out that there were really no treatment options left that really there was an evidence base for. We were able to get a grant from the EDCTP, which is a partnership between European and developing countries to improve clinical trial capacity. And we're currently actually analyzing data for these 3 studies, looking at dihydroartemisinin piperacin, artesunate amodiaquine, and IV artesunate. There are issues with the use of artesunate amodiaquine in countries that have a high prevalence of HIV, because amodiaquine has been shown to have a hepatotoxic side effect amongst patients that are on efavirenz. So that drug is a potential, but it's unlikely to be used in countries where you have high rates of HIV. And I wanted to bring up this slide on capacity development. A lot of the speakers today have spoken about Seppi Mary and David Back. So Seppi Mary was my PhD supervisor. So David Back was not my PhD supervisor. He would be the equivalent of a grandparent in that sense. So Seppi came to Uganda about 12 years ago to set up a PK unit. At the time, she was told it was career suicide, and there was very little understanding within Uganda or any even desire for pharmacokinetic studies in the country at the time. I remember when we sent in all the protocols that I've described, we got a lot of feedback from the IRB. Why do you want to take all that blood? And what exactly are you going to do with all that blood? And there were many times where it was quite discouraging, and it actually looked at times that the program would shut down. David didn't tell me this, but Seppi told me. He was one of the few people that encouraged her to make this decision and to set up the program. 10 years later, we're still working together. We're currently running a drug-drug interaction study looking at dolutegravir antimalarial drugs in Kampala right now. And we have several other studies with other collaborators that have been mentioned. Importantly, I think, is that there's now greater ownership of these resources. The Institute has taken greater responsibility for pharmacokinetic studies at IDI. And the WHO has awarded us a grant to enhance this capacity even further so that we can look at drug-drug interactions and other early phase studies for emerging infectious diseases, including Ebola and other hemorrhagic fevers. The point being is that you don't really want to wait until there is an outbreak and then you try to figure out whether your antimalarial that you would administer along with whatever you're giving to the patient has a drug-drug interaction or is toxic. You probably want to do some of those studies in healthy volunteers before an outbreak occurs, because during an outbreak, you really don't have time to figure out what works and what doesn't. So to David, we just want to say thank you.